Hey Rich, how's it going? Another session.
Doing well. Good to see you, Mark.
Good, good. Hey, listen, I think what we've been talking about is in our podcasts to have like a structured discussion just based kind of on the feedback we've been getting. And so I think what we're going to talk about today is a paper that is just coming out that came across the wire, if you will.
Right.
And it's called, and I sent it to you, and
Yep.
so we'll discuss it. It's called Making Clinical Practice Guidelines for Dentistry More Patient-Centered Through Patient-Reported Outcomes Integration. So this is great because it's right up the alley for from what we've been teaching.
Yep.
That I will argue that dentistry has not done a very good job about. So anyway, with that said, any opening comments about your thoughts on the paper?
That was a great paper. I really appreciated learning a few things, like learning about the patient. Let me get it right here. The patient reported
PONs,
outcomes, a PRO,
PRO.
instead of the other types of metrics that are almost always done. And basically, if I could just let people know what a PRO is,
Please.
it's an outcome that's captured from patients without clinical interpretation. It's basically what the patient feels, and if we related that to Airway, it would include sleep quality, daytime fatigue, brain fog, snoring intensity, etc., etc. It's their experience, and I think it's really important to focus on this in a completely different way that we normally treat dentistry. You know, Typically we like to do a little dentistry and then no news is good news. If the crown gets cemented and they don't come back, it must be okay. But what PRO is, it's all about how did that crown that I cemented on you, how did that help you? What experience did you have as a result of me delivering that? And I think most of us are almost fearful of even asking a patient, how did that intervention I just did, how did it work for you? But for airway dentistry, it's everything. Everything. All of our decisions ultimately have to be made based on how we are impacting the patient in a positive way, a way that they can articulate, a way that we can record. To me, that's the big point of the paper. And you're right, Mark. It absolutely ties in exactly with the way we need to practice airway dentistry. I mean, what do you think? Is that
Yeah,
what you
yeah,
saw?
no question about it. But I would argue even beyond that, it's not just airway dentistry, just dentistry in general, and that's what this paper was about.
Yeah.
And if you remember, we talked a little bit about this a couple of podcasts ago about the study doing a systematic review looking at orthodontic care,
Right.
uh, assessing um, patient-reported outcomes, and that one of the main conclusions was that orthodontics as a specialty has done a very poor job
Yeah.
about it.
Less. What was it? 20 to 30% of the papers even address it at all. Something like that.
Exactly. And so I'll go back to really the way we were trained. Now, medicine, um, probably in the last 10 years, has really been focusing more on this only because the payer government is starting to say that for cost point of view, you're going to be held responsible if you don't reach your outcomes because business as usual it is not working. It's expensive. And this paper actually talked about that. So um, I would like to just mention probably about 15 years ago, Philippe Hujoel, who's a periodontist, but also is an epidemiologist, well-known epidemiologist out of the University of Washington, wrote a paper. And I had the privilege of working with him and Mike Newman in the Journal of Evidence-Based Dental Practice when we launched that. Um, gosh, I want to say it's probably been 20 years now.
About 20 years,
Um,
yeah.
when the plus when the whole movement about the evidence-based approach was very controversial. So David Sackett from McMaster University in Canada had already been talking about this, wrote a book about it for medicine, and medicine adopted the mantra of what we know as evidence-based decision making, called evidence-based medicine. And then the American Dental Association came up with its own position maybe 3 to 5 years later. Okay, so at the time, if you remember, it was controversial because everyone was saying, look, it was a in my hands mentality. It was like, this is the way you do it, mentorship driven techniques on doing things. And you can't tell me how to do that. And so, what this whole movement did in upsetting the apple cart said, no, 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 we have to actually have evidence that how you're doing it is the best. We can't rely on that your mentor told your mentor that told your mentor.
Well,
And so,
I would also say that for a lot of people that would claim that they're making an evidence-based decision, even though that term wasn't even really being
it wasn't
used,
even around.
yeah, they were basing their decisions on laboratory studies.
Yes.
Laboratory studies were
Low
everything. I mean,
level in vitro studies. Yes.
absolutely, particularly in prosthodontics. I mean, really heavily based
100%.
on numbers on testing devices, and that was how you made your decisions. And those were the elite leaders of programs around the world, the ones that used that data. And it wasn't until people like Terry Donovan came along and said, "Hey, look, guys, we have to go way beyond what the lab says. You cannot take laboratory results and equate them with clinical realities. We have to think differently." And he was saying that sort of thing right about the time that evidence-based dentistry was starting to gain some traction as well. I interrupted, so continue
No, no,
on. But
you're
I
no,
wanted
but
to just frame it that way because I can tell you that we walked around with our chest up, pumped up, and like we were speaking the gospel truth, and it was all based off of just laboratory studies and
yeah, in vitro. I
in
mean,
vitro. The notion of a
honestly,
vivo study, an RCT, or any systematic review is completely it wasn't even mentioned.
I mean, in retrospect, it's embarrassing if you really look at the science because, at some level, down material science is, it's a good start, but people were starting to understand that there's a difference between, fatigue versus catastrophic failure when they
Sure.
were,
Right.
testing materials with an instron, because that's not actually what happens, right?
Right.
And so
Right.
that was kind of like, the beginning. But going back to Philippe Hujoel, he wrote this paper that, has stuck with me, and it's so meaningful, and certainly have incorporated the principle in what I teach in my philosophy with airway focused dentistry, which is he talked about the difference between tangible and intangible outcomes, and the outcome, or I'm sorry, the magnitude of the outcome. So kind of to break it down. Um, so a tangible outcome is patient centric. It's something that's tangible to the patient, like they have less fatigue, less anxiety, less depression, less temporomandibular joint pain. They have better range of motion, less stiff necks, uh, et cetera, et cetera. Whereas intangible, so we were never trained to have that kind of an outcome. First of all, how do you measure it? It's too subjective, is what we were told. So what we were told as a provider that's more concrete is something that we can measure, right? Like a
Right.
margin,
True.
a probing depth, whether you're getting bleeding on probing or not, um, whether you can get an occlusion with the dots all lined up where we could see the functional cusps,
Mhm.
something that's absolutely intangible to the patient. I mean, there were world-class, high-level scientific sessions. They were all about that, that if you had an audience full of patients, they would like it'd go way over the head. They would say, "Oh gosh, these are real like doctors. This is way above my pay grade. I'm just gonna trust the guy with the white coat." Well, that's really flipped because patients are now taking the frustrated, they're taking the control of their health in their own. They're getting educated in the age of information,
Yep.
and so now everything's kind of gone towards quality of life.
Right.
That's an actual qualitative metric. And outcomes are really being measured more by, well, how is this improving my life? So, for example, if you have, you know, you know, prostate, cancer or whatever, going in and removing the cancer. Um, yeah, that's a good, but then now you're impotent, you have function you can't feel, and it's kind of like you solve one problem, but from the patient's experiences, I don't know. Am I really better off? Yeah, maybe, maybe not. Could I have outrun this slow-moving cancer, for example? So, so this paper in dentistry talks about it, but been in medicine now for a good dozen years or so. And ironically, this is what we've been talking about for 15 years. So think about what we talk about is one of the underpinnings are to measure the medical indications for why we would recommend a dental intervention. So it's not about palatal width. It's not about palatal height. It's not about a crossbite. It's not about, the occlusion just hitting on three teeth. It's about um, can you sleep well? Are you refreshed? Can you breathe through your nose well? How are you feeling? Is that next symptom gone? Are your temporomandibular joint symptoms gone? And you can actually measure that. So what do we teach, right? We use high resolution pulse oximetry. It's imperfect, but it's qualitative. There are other measures as well, but that's just an example. Fatigue severity scale, it's a validated medical metric.
Hmm.
Kind of like the sleepiness scale, whether it's Epworth, Stop Bang, Berlin, any of those.
Right.
And we're looking from the patient's point of view, and then you treat. So let's say in medicine, then you put them on CPAP. And then you go ahead and measure an apnea hypopnea index. So before CPAP, let's say the index is 30, you're on CPAP, and now it's 10. And if you talk to an obstructive sleep apnea patient, they might not feel that different, but because you're told that that index is less, you feel like, okay, I'm better. I'm going to trust my doc. That's what makes treating obstructive sleep apnea difficult is patients often say, ah, the heck with that. I don't want to put on this esophagus. I don't feel that different,
Right.
and so that's a metric that is not necessarily patient centric, but what is if they get up feeling more refreshed, maybe their memory's better, maybe they're less forgetful during the day, they have less anxiousness. So those are the metrics that we really want to look at. Well, the great thing about this paper is it's bringing to the fore in dentistry patient-centric outcomes. And this is the hot topic. And I guarantee you, moving forward, this is not going to end because we are now moving into the era where business as usual is not going to work for the patient, or it's not going to really even work for our training. It's going to be patient outcome measures, what the patient is saying. And we've been teaching this for 15 years. And now everyone's kind of catching up. So it's not molar angle classification one. It's like now I'm, have a better cognitive function during the day. I have less mood swings. So this is what I thought was really interesting about this paper. So I'm going to just stop here and see if you have any comments.
Yeah, I think it's really interesting, but it also is quite challenging because our research communities are not really set up this way. They don't really, it's going to take a significant amount of learning and retooling in the research
No
labs of the
question.
dental schools. That's for sure.
Well,
And
let me just stop you there for a second.
yeah,
Isn't this what just happened with this move towards evidence-based dentistry?
you're right.
Before that, it
Absolutely.
was in my hands mentality and it was
Yeah,
very disruptive,
you're
but
right.
now it's kind of normal.
Yeah, I think that's really true. And I can hear this being taught in the dental schools in the first course that a student takes in research methodology. I can hear this starting. I can see that this can happen. I believe it'll happen, and it will change things. I did want to uh, point to some potential problems with this approach because of the potential for bias or influence on patients. For example, like in the example you gave about the CPAP needle, it moved from 30 AHIs to 10 AHIs, and the physician says, "Well, look at the metrics. Look what's happened here. You're doing so much better." And the patient goes, "Well, gosh, okay, doc, I don't really feel that much better." And he goes, "Oh, no, no, you're doing a lot better. You really are. You must be feeling less tired." And in this, there may be, we have to be careful as care providers to avoid that type of engagement with a patient, if particularly if it's a paper. I think also it's it brings up the concept of this minimally important difference with patients, the MID
Yes,
factor. And what that is the smallest change patients perceive as meaningful. And so we can have changes that might even be statistically significant in a paper, but it didn't move the needle for the patient at all.
right,
You know,
right.
and so when people start treating to, let's throw a number out there, 38 millimeters of intermolar width. Oh, I nailed it. I got my 38. That's a 25% improvement over what they started with. Therefore, mission accomplished. Time to straighten the teeth and finish the job. And to me, that is wow. I mean, we have to think very, very differently. And I want to be. I could see a lot of potential for bias if the researchers are not careful, very, very careful. It's hard to double blind sometimes these things too, and I just don't know. Um, well, let's just put it this way: it's a learning curve, and there's gonna be trouble along the way, and people are gonna talk about, oh, this is a great PRO paper, this and that, and then you find out later, or you read between the lines that yeah, it had a very profound impact on patients, but there was so much bias and so much leading the patients on that the data was skewed. And I think that it's just something we always have to be aware of, you know? It's like the 3-star Michelin restaurant that serves the same dish on a fancy looking plate. It becomes suddenly a better tasting meal. And I worry about the influence, the sway, more than ever before. Sway is such a big part of everything. And so I do have concerns, but I do believe it's also the 100% needs to be done. Can you share a little bit about maybe what medicine has done to not let that happen, to maintain the high level of evidence from these types of, from a different approach like the grade approach or, looking at MID changes in medicine? Do you have any thoughts on that
Well,
work?
I
Because
think,
I want to feel that there's hope that we can do better.
well, yeah, I would say that I don't think medicine's really that exemplary in it. In fact, it's very, very clear.
Interesting.
Let's just look at the whole evidence-based um, medicine approach, where today you want to talk about biases. You're just talking about biases within the clinician, but how about the researcher? So in medicine, where you're looking at, say, pharmaceutical A versus pharmaceutical B, there's really good studies that the other stakeholders have really dirtied the science to where maybe they bury
Mm,
negative findings. And in fact, Richard
right.
Horton, the past editor of the Lancet, has gone out and say you just cannot even trust the um, um, the conclusions anymore. It's
Hmm.
it's so biased. I mean, this is the editor of the Lancet, and then Marcia Angell, editor of the New England Journal of Medicine, essentially said the same thing. So they're basically saying that industry has bought academia, and so it's really kind of thrown a monkey wrench in the works. And of course, we all suffered through the controversy having to do with COVID as an example.
Sure.
And that we're now, in retrospect, looking at, not to be political, but just looking at what is really the science. I mean, you could start talking about immunizations and things like that. So I think we've got to go back to really looking at um, unbiased science, and randomized controlled trials are not really the standard. And in Europe, they've really been going more towards systems medicine, bioregulatory systems medicine, looking at, you know, less siloed thinking. And so that's a big controversy right now, is really changing it. And what's going to be driving it, interestingly,
Mm.
which is one of the main points of this paper, was looking at how current dental systems, they're treatment dominated and ineffective at reducing the global disease burden. So it's the same thing in medicine.
Wow.
The payers are going to say, look, you've done this surgery 3 times and it's not made the patient any better, and it's cost exorbitant amount.
Right.
We're not doing that anymore. So I think at the end of it, the payer is going to kind of pull back and say, we have to hold the provider more responsible for the outcome, because otherwise, let's just try this procedure and the payer's paying for it, and it may or not work. So right now in sleep medicine, we know that, for example, let's just look at, because this is kind of germane to what the podcast is about, breathing and sleep and all that, Airway, is that the New England Journal of Medicine did its review on outcomes regarding the use of CPAP long term. And one of the big arguments from the Wisconsin cohort study was that people who had an AHI greater than 5 had a significantly higher risk of stroke, atrial fibrillation, um, MIs, dying
Just
from,
five.
what's that?
Just five.
Just 5. In fact, they had to stop the study the way they were running it. I mean, it's still going, but the death rate was so high. From an ethical point of view, they had to, um, take a different ploy in how they collected the data with the patient. And so what they found in retrospect was that cardiovascular outcomes have not really improved if you're using the CPAP. And that came out in this white paper some years ago. So, okay, one of the main reasons was that compliance was less than 30%. Okay, it's not to say that if you didn't read the paper that CPAP doesn't work. It was just saying that people didn't use it. They would use it the first half of the night, part of the time, and then they take it off. Well, what's the riskiest time? It's the second half of the night, number one. Number two is they're now finding that by pneumatically stenting the airway open, it actually upregulates, and we've talked about this,
Mm-hmm.
a hemopoietin, which is an inflammatory marker that increases cardiovascular risk. and it downregulates VEGF, which is a cardioprotective um, um, peptide. So, the position of the provider in Airway is kind of like with physicians. It's not a black and white like a margin of 50 microns or a probing depth of 3 millimeters or a radiographic lesion that's into the DEJ that you could kind of do. I mean, those are kind of things that you could look in singularity and say, I've got to intervene or not intervene. This is more imperfect because you've got patient compliance and all these other factors. And so it's not about flexural strength, it's not about fracture toughness and chipping. It's really looking at the why and looking at, does this make a difference to the patient? So I've sat in on, lectures where everyone's all wrapped up around the axle about chipping that the patient's not even aware of. How many times do you see these patients?
Right.
They've got the mesiolingual cusp of, the second molars, and we get all freaked out from that, Emax layered. And so now we're going monolithic and as if that has anything to do with for the patient's quality of life,
Right. Right.
right?
Right.
So I think,
Exactly.
it's not a black or white. And I think this whole discussion that we're having really is about the main member of our team,
Hmm.
which is the patient.
Yeah. Hey, I
I mean,
wanted
what
to.
makes the difference to them?
You made it. And you bring up so many things I want to respond
Please,
to.
please
One of
do.
them was, uh, after getting my own personal sleep study, I was they didn't really say much to me. They basically said, "You're getting a CPAP." I said, "Well, I already have a CPAP." They go, "No, no, we're going to give you a new one." And so the insurance company calls and they let me know that it's going to be coming in the mail when it shows up. Make sure I check in with them. Make sure I know how to set it up. And it was a lot of hand holding and very very helpful. Text messages, phone calls, follow up emails. And then on the device itself, now of course they can all remote in and they know exactly what's happening on every single device that's out there. They know 100% what the compliance is. They know if you've worn it for 3 hours or 7 hours. They know what level. They know if you've monkeyed around with the levels. If you found
Telemetry.
the secret menu, they know exactly what you did. And I think that's fascinating. They also interesting because you brought in the whole idea of the payers. Uh, you know, it was an interesting thing. They said, we're going to give you the CPAP, and if you wear it continuously for 60 days, if you wear it, then we will provide you with XYZ and more supplies, or you'll get better benefits, etc. So it's like, wow, they're really taking charge of this. So they want to make absolutely sure that this intervention is being used properly. I mean, we don't do anything like that in dentistry. I mean, it's nothing. I mean, we have
Right.
recall or recare appointments, this kind of thing. And if they miss a recare, what do we do? Oh, don't worry. I'm glad to see you. Just, ha ha ha. And maybe because it doesn't matter. I don't know. I was also thinking one more thing I wanted to say, and I'm not
Please.
going to name names about anything, and because we're not trying to be political, but we want people to think. We want people to think. So one of the largest drugs that's prescribed, it's in the top 10 prescribed in the world. I won't mention it, but it's supposed to have a dramatic influence on early death due to cardiac events, strokes, and things like this. And when you look at the real good research that's done out there, not the case. It hasn't moved the needle hardly anything. And yet everybody's on board with it because there's a lot of money. And when you're a medical research enterprise and you've got 25,000 square feet of medical school space and 60 research postdocs, et cetera, and all kinds of NIH grants, and everyone's patting you on the back and naming wings after you. and the money comes pouring in and pouring in. Everybody wins, and yet the doggone intervention isn't even really working. Not to mention the fact there's no MID for the patient. If you give a patient something that's supposed to make them live longer, they'll how can they ever tell you they're going to get better, that they're better? If you give me some medication to help my heart last longer, what is my PRO? I mean,
Yeah,
I
I
don't even
totally
have one,
agree. So this
right?
is the yeah, this is the problem that the stakeholders, in this case, the pharmaceutical industry, is kind of hijacked based on, I mean, really not that different than what J.R.R. Reynolds did with smoking.
True.
They were convincing us. And of course, in Europe, they already know, I'm going to take a stab at it. Statins, maybe, is what you're talking about. They don't, it's almost considered a poison in Europe. And so there are studies to actually show that it's a big problem. No question about it. Um, Let me just mention the very well-known study, similar, looking at a similar question called the CAST study, the cardiac arrhythmia suppression trial, which was looking at two antiarrhythmias. So in the study, they looked at, and this was a lesson that was learned in medicine, where they were putting pharmaceutical A against pharmaceutical B for heart attacks. So um, for those individuals that had had a heart attack, they wanted to put them on this quote unquote better antiarrhythmia drug because it showed efficacy or better efficacy than the traditional antiarrhythmia in controlling the arrhythmia. Therefore, you're not going to have that second heart attack or less of the chance. And what they found was that, yes, pharmaceutical B, the new antiarrhythmia, did do what it was supposed to do in comparison to the gold standard antiarrhythmia, that it was better at controlling the arrhythmia. But there was a really interesting conclusion in the study that although it was better at controlling the arrhythmia, the death rate was significantly higher than antiarrhythmia A. So we now start getting into true endpoints versus surrogate endpoints.
Mm,
So as a provider, we're using a surrogate endpoint, assuming that it really is meaningful to the true endpoint. Well, what's a true endpoint? I want
mm,
to live longer.
right,
Um, the surrogate is having not having the arrhythmia.
right.
So we've got to be very careful
Yep.
about, from a patient's point of view, what's really important versus the guy in the white coat that says, look, you've got a better chance in controlling this arrhythmia of not dying sooner. And yet, one of the side effects is to actually increase the death rate.
Right.
So yeah, it's complicated. The other part of this paper, Richard, is that was very interesting. I found um, where they talked about prevention strategies
Mm-hmm.
that in dentistry, well, I'll just also say in medicine, is that they're inadequate and misdirected. So we could talk to our patients about not having fermentable carbohydrates, you got to brush better, and do all these things, but you don't get paid for it. So the system is set up to just do, right?
Right.
So you need to
Right.
change it to where one of the patient's um, true endpoints would be that their cost of care goes down over time because they're needing less dental intervention for, let's say, caries.
Mm,
That's something you can measure over time
mm-hmm.
versus the complaints we hear all the time. Every time I'm in here, I've got another cavity, you've got to do another filling. And so the system's not incentivized really to do that. And then the system that is incentivized in medicine is not very well monitored. The multi-billion dollar nutraceutical uh, supplements um, industry, lifestyle industry, where you get these gurus, health gurus, that really don't have the background. And they have people lined out the door paying a lot of money for something that may or may not help. Now, I'm not throwing them under the bus, but just to outline that in healthcare, it's not so black and white.
I
Our
do
current
see,
system's not
yeah,
working,
yeah,
right?
true. I do see, for example, I have a different medical insurance than my wife does. My wife's medical insurance is more proactive in prevention. I mean, they're sending her. It's time for your colonoscopy, and they're making sure it gets done, and they're getting the shots, and they're also doing stool samples to make sure something else isn't happening, and they're constantly talking about health practices, or they have memberships to gyms at discounted rates. They've got food delivery services. I was just really trying really, really hard to keep the big medical costs down because and I we could say altruistically, wow, it's great, they really care about people, but also it's good for the bottom line.
Awesome.
They're healthier patients in this HMO. That's going to cost the hospital less money, and they're going to do
Yep,
better.
100%.
Yeah,
And this is where um, large corporations will have these programs where
right.
the employee comes in to HR and they're given the option that if you sign up with the corporate health plan where you get a gym membership, you have to show that you're going to the gym 3 times a week and that you're keeping your weight down and that you're going in your regular checkups, and you're doing all the right things and checking all the boxes. What they found in these large corporations, it saves millions in not only healthcare costs, but increased productivity
Sure.
because they have less missed days of work,
Absolutely.
more productivity when they are at work.
Yep.
And so really that's where we need to go. And so in dentistry, we've got to do the same thing. And what I'm proud about, Rich, is what we've been teaching is pretty much this approach of patient reported outcomes. And here's kind of the nice silver lining about it that I've learned is when you engage the patient with the medical metrics that they can actually tangibly feel the improvement with, let's say, a fatigue severity scale because they're breathing better, they're sleeping better, and their fatigue severity scales improved, and they tell you. And then for us, we actually measure it quantitatively,
Right.
where we see their heart rate drops.
Right.
The patient doesn't care that much about it. I show
Right.
them, they go, wow, that's great. But what they're really happy about is they're 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 just feeling they're having less coffee, their moods are more elevated. They want to refer their family, their friends.
Sure.
Whereas if you do beautiful veneers or full mouth rehab, it's expensive. Yeah, I like it, but my neighbor, I don't want to put them through that because that's a lot of cost. I know they can't afford it.
Yeah. Yeah.
Whereas if it's improved your quality of life, they're going out and talking to everybody about it in social media and otherwise.
Yeah.
So from the clinician's point of view, although it's more difficult, it's different. It's rewarding um, every day getting these patients telling you, but also the phone's ringing off the hook and they want to, can you help me too? And
Right.
that's what we got into healthcare for.
Mhm. I would say that uh, this type of dentistry is, because it is definitely leaning more towards the stochastic medical arts, if you will. We don't know always what's going to happen. It's a little more uncertain. We make conditional recommendations rather than uh, this is it. This is the only way to treat this. We also are looking at moving the needle with the MIDs from the patient. We're grabbing onto those little improvements. We're seeing this, and I think for some dentists, it's going to be very uncomfortable. It's just not the way things they're used to doing. There's an entire there's an entire huge portion of dentistry, unfortunately, that could give a crud about this unless they see the dollars in it. And for the group I'm talking about, that every filling is a crown, and every crown is a root canal, and every root canal is an extraction, every extraction is an implant. And the ones, and they've got a model that's very, very top and bottom line successful. The dentists that are more boutique in nature, that are more fussy about margins and ethics and contacts and occlusion and elegance and all of that, they have their way, and they've built this practice of patients that trust them, and they know they've done well when they this kind of thing. And so what airway dentistry does, it shakes it up. And coming at this from a relatively new airway dentist, this is a big part of it, is being okay with not always having you don't always get the same outcome. It's different. And just the way, like when I watch you interpret an HRPO report on a patient, the variability that exists, the symptomology. Sometimes you'll ask a question to the patient and you're expecting, oh, they're going to say yes, they're fatigued. And they go, no, I'm not. And and you're like, oh, and then it doesn't derail you. You just go, okay, that's one factor. Let's move on. And because there's a lot of different pieces to the puzzle. I think it's a little bit of an art form, perhaps, but it's not so difficult that a new person can learn it. I mean, if you're open minded, I think that you can start talking to patients very comfortably, and without having that dentist mindset of margins, occlusion, and perfection, and the best patients, one you deliver the crowns on and you never hear from them, or they come back and they always love you, whatever the case is. So I think that's a big part of it. Your thoughts on that?
Yeah, if I could unpack that just a little bit. First of all, I'm going to say, okay, don't get us wrong. I love nice margins. I love nice occlusion. I love a beautiful arc of smile, beautiful ceramics. All that stuff's great.
Yep.
But honestly, in my experience, um, what we do in our clinical protocols are very predictive. In fact, I'm going to say, in many regards, they're more predictive than traditional dentistry. I mean, I am very surprised
Now, is that
that
just you, or is that everybody?
I think it's when you apply the principles that we teach. And this is the problem, is getting someone from being lazy about really gathering the data. I
Okay.
mean, this is why weekend courses are still blowing up, because it's a technique that you can do just like anything else, like margins, on how you plan the tabs and place the tabs and cement the bands and all that. That's just procedure. But what gives it meaning is how it improves the patient's life. And I find it is rare that I don't get the outcome that I would expect. In fact, I don't think I've had a case that I've not. What I've had is maybe it's not the level of care, the level of outcome that I would have wanted because of the things that I cannot control, which is compliance.
Hmm.
And so I think what we have to come to grips with, that we don't very much do in dentistry, is the compliance aspect of it. Now, physicians know, they're going to prescribe a pharmaceutical, if they can, that's BID, or before one that's TID, right? Just because they know it's
Hmm.
easier to take a pill twice a day versus three times a day, or
Right.
one time a day. I mean, they're dealing with compliance and the pill boxes and stuff. As an example, that's the variable, is the patient, and yet they're our boss. So I think what the provider has to learn to do, that we weren't trained very well in, is in really coaching and engaging the patient. we're just kind of like, oh, you got a cavity here. Let's put a rubber dam on, lean back, let me do it. I'm going to do my thing. Or let's straighten your teeth out. Let me bracket it. Come in every once a month. I'll change the wires. They have very little say in it. And then when it's relapses, it's the patient's fault because they didn't wear the retainer. So, I mean, that's just the way we roll. I think the difference in how we think is in Airway is really, first of all, understanding our protocols. And I have to say, in 15 plus years in teaching these courses, that it's been very uncommon that I have had a doc that goes through it and says, this is like full of it. I don't want to do it. And I know because I have read every review that we do, the course reviews through the years, and I think the biggest criticism is like too much information. The pace isn't is too much, or I needed more instruction. Okay, but
Yeah, yeah,
at the
yeah.
end of it, it's like earth shattering. And I think my failure has been then how do you translate it on Monday to make money? How do you make money doing it this way? And I think one of the things that we've retooled is that reality that we have the responsibility, like a dental school,
Hmm.
is not only to teach the techniques, but I mean, a dental school will close and fail if all their alumni go bankrupt because they can't make a living, right?
That's
It's
true.
in any, I mean, it's in any profession. So
Right.
you're paying all this money for the education. You've got to get that return on investment. I get that. That's a reality we healthcare providers get a little uncomfortable about. But the reality is that um, you could do very well doing Airway, but it's very different. And these are some of the things that we teach. And part of it is really understanding that you've got to follow the protocol and the workflows and do A, B, C, and D, and it'll blow up. So I think that I would just argue and maybe push back a little bit in that I don't see it as that difficult. And um, we look at structure, function, behavior, everyone's different, where maybe we see a narrow palate, we expect a lot of nasal resistance. When we look at our CDCT, we're surprised that it looks like it's very patent. We
Hmm.
wouldn't expect it. Okay,
Right.
those exceptions happen,
Sure.
but then we find out that the function's terrible. So, I
Mm.
mean, I think you have to look at all the variables collectively versus what we're used to is just looking at a radiograph standalone by itself. And of course, we teach.
Wait! Before you go too far, because not everyone's gonna pick up on that. So when the patient looks phenotypically like they're going to be a problem structurally, we look at the CBCT and it's amazing. And like, wow, that's not the case after all. But then you say they're terrible functionally. Give an example of what you mean.
Well, I'll just say, like what Christian Guilleminault mentioned to me many years ago, he says, look, you can have a very large airway, appearing airway, like a mid-sagittal CBCT
Okay.
cut. And people say, oh, there's not an airway problem there. You get a radiology report, low risk for, you know, airway problem.
I read them all the
And
time.
yes, and that's not true
Right.
because you can have, as he would say, a large looking airway that's
Right.
super collapsible,
Sure.
and then a
Yeah.
much smaller one
Right.
that has really good function. So you have a small airway on a CBCT, but she happens to be an opera singer, or they play a wind instrument, the trumpet, and those muscles are uh, um, very strong and don't collapse.
Right.
But that's why we look at structure and function. So, also volume doesn't have anything to do with it. It's really the constriction. So these are all things we get into the principles in
Yep.
airway, but we're kind of used to looking at black and white,
Yep.
right? When that triangle shaped demineralization pattern on a bite wing gets to the DEJ, it's time to intervene, right? I mean, it's versus remineralized. We're used to thinking that way.
Yep.
So I think the difference is stepping back And I have found it professionally much more satisfying. And learning how to talk to the patient and explain it. Now, if you're an introvert or don't know how to communicate, then it might be more of a challenge.
Hmm.
If you don't want to talk to the patient, but just remember, dentistry is a healing art.
Hmm.
And that means that you're engaging another human being, just like medicine.
Can
So
I wanted to read you a quote and get your reaction. Okay, does
please,
that sound good?
yeah,
Um, Airway dentistry may in fact be the field that forces dentistry to grow up methodologically.
yeah, wow, where'd you get that from?
Oh, I have my ways.
Make sure you put
Well,
your hand. I think you're right.
yeah,
Yeah,
right. Because my gosh, it it's amazing what has just transformed in my own practice since I've graduated from the AMR, and what changes I've seen. Uh, and I'm tooling up. It takes a lot of effort to get your whole staff on board and train them all and everything else. It's not impossible. It's very doable, but the rewards are huge, and it's fun. It really is. It's fun
yeah. I mean,
because
it's
you become a detective, you become a communicator, you become more than just a dentist. You become somebody
you become
who
more
is
than just
true.
a mechanic.
Yeah.
So I argue that dentists that this is not a specialty of dentistry.
Mm,
It's part and parcel of how we think. It's just a
mm,
way of thinking. It's not what we do um, as a specialty. It's how we think. And so maybe we'll end the podcast there. Is I think that what we're teaching in our courses is a different way of thinking that, by the way, I think it also applies to the techniques we do,
mm,
is getting back to critical thinking, super rewarding. So
for sure.
we'll leave it there. And hey, Rich, what's your learning experience or moment of the week? Do you have one?
Oh, it's like interestingly, today I had two patients, three airway patients. One that came in because they
Wow,
are an
good for
airway
you.
patient.
Yeah,
What?
good for you. That's great.
I had one airway patient come in because she knows she's gone through the workup and we're getting ready to move on to the next phase. I had another patient come in that was just here. She's a dentist and she just wanted to get a dentist to look at her, for once. Even though she's in charge of a big dental group with a lot of dentists, she just didn't want to have them touch her. And then the third one came in for a restorative procedure. And before we even started, I knew immediately, phenotypically, she was a high risk for airway issues. And we just started talking. And the same thing worked with the other patient, the dentist, the new patient. We just started talking and not starting the conversation with something lame like I used to do, like, oh, wow, how's your sleep? Something
Yeah,
like that,
right.
which is, I get it. I get it. It's like you want to shoot for something that you feel like you can answer, but, and just sort of very organically just talking to them like a human being that cares about them and not zero in on what you can tell them, but what they have to say to your questions and listening. It's really interesting. And the dentist was really fun because she's a patient that has significant amount of recession. I said, wow, you've got a lot of recession, but you have no periodontal disease per se, not a biofilm induced periodontal disease. I said, why do you think that happened? She goes, yeah, it can't just be my brushing. And I said, oh, I noticed you're taking this medication for GERD. You have a little bit of gastric reflux. Yeah. But I'm trying to treat that with diet. And I'm like, okay. And I noticed you have an open anterior open bite. I said, why did that happen? She goes, well, you know, my mom had one too. And so I said, so it's genetics. She goes, yeah, pretty much. So but this is hey, take me a few years ago, I would have said the same thing. So for us to just not judge her, but just listen and kind of say, okay, formulate your responses in a way that helps them understand more about what the why behind things, particularly for the dentist. It was just really fun. And so by the time we're finished, she says, what's next? And then the patient I was doing the restorative procedure on, she's like, thanks for the restorative procedure, but all that other stuff you were talking to me about earlier, when can we continue that discussion? So I'm like, wow, that's different.
Yes.
So the
Yeah.
learning, I don't know
I
what the
love what I'm
learning,
hearing.
you know what I'm talking about. This
Oh,
happened to you so
totally.
many
I
times.
love what I'm hearing. So I'll just comment on where you are is, and everyone goes through this, is first you see it, and just think about people who've gone through the AMR that we've sat there at the breaks. It's like all of a sudden they're looking at themselves or their spouse. Everybody, like, I've got the problem. And then so you get to that point, that's stage one. Then stage two is where you actually start to talk to your patients about it. And initially it may be a little awkward because it's kind of different, right? But then it gets to like where you are, where you
Hmm.
just do exactly. It's this thing that you organically learn by just asking the questions, the answers to which you already know, and let the patient take you there. And then you do that every day. And all
Hmm.
of a sudden, it's easy.
Right,
And I could just tell you um, that your staff, like I have my staff,
right.
they've been in it. They all need the treatment. They know it. They see from everybody. They come in, and you get so connected to understanding, seeing patient after patient before and after. The patient will say, "Oh my God, I just had all this, and now," and they go, "I want that for me too."
Right.
So it's not like you do veneers, you go in with a smile, and then you do veneers, and it's kind of nice, but you have a decent smile, so it's not that. It doesn't move the needle that much.
Right.
But this is really material. So I
Hmm.
love hearing what you say, and that's
Thanks.
that's great. You had a day like that, where
Yeah,
every day would be like
it's
that.
nice.
Yeah, yeah. So thanks for sharing that, Rich, and um, great podcast. I think,
Yeah, I love the paper. It's so important.
yeah. And we'll next week we'll pick another paper, and I'll send you one, or you send me one, and we'll talk
Sounds good.
about it.
Sounds good.
And otherwise, we hope everyone um, learned something. Maybe it got you upset. Just contact us and think about taking the AMR in March. So with that, I'll talk to you later, Rich. Take care.
Take care, Mark.
All right, I'll see ya. Take care, buddy.